the nature of the beast. If you understand that, and you understand that how the blood flows from left to right, okay, leads you to understand that the numbers in certain instances cannot be congruent. Okay? So when folks say that this machine doesn't work or that machine doesn't work, they really don't understand how the machine works and what either side does. Okay? Because we all know that swan sits where? It sits on the right side, right? Which is a low pressure pump. But flow track sits where? On the arterial side. And monitors, really, if you want to get technical, it monitors flow from the aorta. The same as a pulse oximeter, only monitors blood saturation in the aorta. Even though it's on your finger, right, SpO2, there's only less than 1% of oxygen taken out from here to here. Okay, so they're not the same. I liken this, what happens right here. I live in Pittsburgh, and in Pittsburgh we have a lot of tunnels. And at 3 o'clock, traffic kicks up. We have the big one, which takes you right out to the east, and it's called the Parkway East, and we have the Liberty tunnels. And some jerk every day slows down and wrecks inside the tunnel. Okay? And what happens to the traffic? It flow this way, but very little flow that way. The arterial tree system works exactly the same way. And this is extremely important because I sit here and I hear you talk about CV cases. Okay? If you understand how the body, with its kidneys and the adrenal glands work, then you understand you're going to have a disconnect in certain cases. In cases with high afterload, SVR, SVRI. As those numbers go up, what do? You create a traffic jam here. So what's the body's response to that? So in those cases, we put a swan in and we find out the PAD is low, right? So what do? We give them a bunch of fluid. Where does that fluid stop? It stops right here. Why? Because SVR in cardiac cases is very high. Not only surgical cardiac cases, but also congestive heart failure cases. So you have a lot of time, and especially right-sided failure, where you're going to develop real high SVRs, which means that fluids park here. So the treatment of choice for right-sided heart failure is fluid. It's counterintuitive, but that's really the answer. What you're just trying to do is to go through the system as fast as possible. We know that this is the case because every cardiac surgery patient that gets done, every single one of them, does what when they get warm? Nurses, they pee, right? So what happens? We give them fluid, we give them fluid, we give them fluid. Low urine output, low urine output. And as we watch SVR come down, right, we move the car from the tunnel and the fluid comes into the kidneys and we pee it out and then some circulates back through. It is because of that in early cases, the numbers are not going to connect because there are two different theories on how the numbers are derived. We've had this since 1972. So people are automatically going to say that this is the gold standard. Neither one is incorrect. It is just it's reflective of what they see. So this is seeing low. Why? Well, because the fluid can't move past this. All right. Once this relaxes, guess what happens? And what do we see? See the numbers go and they immediately meet. And it doesn't just happen in one case. It happens in probably 3/4 of the cases. So the answer to why one doesn't work with the other is the fact of how it's done. Now, the strong point of our technology and what we offer is that if I have a choice, which side would I really like to look at? Do I really need to know is working better than the other? Left side. Yeah, because left side is the pump and it's driving oxygen to the tissues. This is flow. We want to see the flow to the distal tissues. That's why this is critical. Okay? The only reason that we knew that there was a difference in between the two before FlowTrack came out is that we used to be able to, in scientific cases and in some real strange places, I could throw a catheter into the aorta and look at a flow. It's a flow-based probe. Now, not many people are going to say, okay, let's just jam a probe up into your aorta. Hopefully we don't tear anything, and we're going to look at how much flow comes past. That just doesn't work like that. It works with dogs, where we got them anesthetized and want to do research. But we don't. But if I really want to know what the left ventricular performance is, I need to look at the left side, not the right side. We looked at this for years because this is all we had. We never had a computer system fast enough to be able to calculate what it was on either side. Now we do. And I will tell you that most clinicians do not understand this. because they've never seen it. They've never had that presented to them. They just don't get it. But it becomes intuitive if you say, okay, doc, I get it. What happens in this patient when I warm them up? Right? Well, they pee. If I have a congestive heart failure patient and they become hypotensive, every single time what do we do with them? We throw them on a pressor immediately, which is absolutely the wrong thing to do because we shut this down even more. Okay, we start off giving them a little bit of fluid. 250 cc's never drowned anybody. And if that allows us to come up, because what happens in CHF, the adrenals release norepinephrine, which cause constriction at the arterial side. The other thing that's important to remember is there was a great study, this is blue and that's red, that when we talk about innervation of arteries and veins, that when we put someone on a pressor, God only gave us so many receptors in our arterial system. The receptors lie in the arterial tree down here at the arterioles. All right, they don't lie up here in the aorta. The aorta doesn't constrict. It doesn't really do much anything. It's a big pipe. Not till down here do I really have the ability, and not even really at the capillary level, to constrict. I constrict at the arteriole level. So in here is where it happens. God also gave me the ability to constrict only 12% of my venous circulation, and that is in the splenic circulation. Yeah. And why is that? Flight or fright. So if I go boom, like that, right? And you go, oh, this guy's crazy. And your body, and you immediately do this, the flight or fight syndrome comes in, and you're like, holy crap, and your pupils dilate because your adrenals kicked in, and everything goes boom, like that. And that 500 cc's of blood that sits here, and then a part of the small bowel goes where? Right back into the system so that we have more circulating volume. Okay, so now if I stress somebody, so I'm out here driving today, it's crappy outside, and I decide I'm going to drive down to PCH and I get whacked. Okay, same thing happens. So in trauma you see that too. Early trauma. So long as I didn't perforate anything and dump a bunch of endotoxins into my bloodstream, I get exactly the same thing. High SVRs, okay, and an inability to send flow past that. Once that releases, so if you think about congestive heart failure patients, when I give them Inacor, Primacor, any of those groups, ACE groups, right, where I'm allowing them to relax that tree, what do? They pee also. You know, so we automatically hit them with Lasix, trying to unload them. That's usually not the problem. So it's a great teaching tool. I see, in my mind, the use of ClearSight is going to be down the road. We're not there yet. It's going to be an understanding patients that we never really looked at before, okay? Because we have an ability, we're not going to throw an arterial line, and usually in women having children, right? But we know there's a great study going on at West Virginia University right now with NextFin. They just went ahead and did it on their own in looking at women undergoing high-grade blocks for C-sections, emergent C-sections. Because what we didn't know is women having C-sections get their blood pressure taken every 15 to 20 minutes. But there's so much undiagnosed hypotension in those cases when we block them real high that leads to some fetal distress. And now we can see that. So there's all kind of nifty things. But it's understanding, if you can articulate what happens here, then all of your arguments are done. And we will find the Hong Lu article and get it back out to you because it really is that important to understand and be able to articulate.